So my name is Ford. I'm a hospitalist and a chief of operational analytics at Providence St. Joseph Health. I'll be talking about large language models in healthcare, mitigating risk, and optimizing workflow. It's kind of a twofer. Agenda, a few example use cases of large language models in healthcare, and then where do those use cases fall on a risk spectrum, and then in a risk-averse domain like healthcare, what are some risk mitigation strategies we can employ to deploy these models safely? And then at the end, I'll talk about Provaria, which is a large language model supported workflow improvement tool to help nurses and medical assistants triage messages from patients. So, zooming way out, large language models are really cool. They can do a wide variety of tasks from the, we could do this 5 years ago, range like text classification and entity recognition to, gosh, we really couldn't do this before in terms of text generation. So some healthcare specific examples of that. Text classification, what type of patient message is this? More on that later. Entity recognition, get all the medications out of this patient note. Document summarization is actually incredibly common in hospital medicine. If I'm, at the end of the day, I summarize my day's events for the cross-cover doc. At the end of the week, I summarize the week's events for the next doctor that comes on. At the end of the encounter, I summarize the entire encounter for the outpatient doc. So a lot of opportunity for document summarization in healthcare. Finally, text generation. This is what all the docs are really excited about. Create a prior authorization for semaglutide. Like the whole document gets pasted out, and it's pretty cool. You'll see I put a kind of rainbow large language model risk spectrum along the side. And I ordered these in kind of a gut feeling, kind of how risky are these? What's the, with large language models, the more you demand of them in terms of expressivity or creativity or unbounded answer space, the greater the risk that you're going to run into something like a hallucination or maybe leave yourself open to a prompt injection. And so awareness that these risks exist and knowing which risks are associated with what use case can help you decide which use cases you want to tackle first and what strategies you might employ to mitigate those risks. And so here's our approach for large language model risk mitigation in this very risk-averse domain like healthcare. So large language models can do a lot of things, but you might try focusing on tasks that have a constrained answer space. So sentiment analysis, positive, negative, neutral, 1, 2, 3 options. It's pretty clear to see if the large language model says purple, well, that's not right. You can filter that out. Text classification, 10s or maybe 50 possible answers. If you're asking a large language model to create a document, it's basically unbounded the answer space. So it's much harder to evaluate unstructured text compared to structured machine readable output. I think following from that, there's also the benefit of structuring your task in a way that can be evaluated using traditional statistical analytics techniques. So if you can frame your product in a way that lends itself to precision recall F1 score, that's going to make it a lot easier to evaluate, a lot easier to get buy-in from risk-averse stakeholders. And I find there's a nice sweet spot between the expressivity of large language models and the determinism of classical traditional programming. So if there's a way you can either formulate the output of your large language model to be machine readable, you can put some rules-based guardrails before the output gets shown to an end user. And I think having a human in the loop is probably useful everywhere, but certainly in high-risk domains like healthcare. I think it's more important that we support and augment and provide co-pilots for our caregivers versus trying to replace them. And with all these risks in mind, I think at least in healthcare, it's probably wise to focus more on the back office administrative components of healthcare rather than the patient-facing components. There's a lot of optimization opportunity in healthcare that isn't in the kind of life or death patient-facing area. So with that preamble and context, I'd like to share with you a challenge we have in healthcare. I'm sure you're all aware that you can get your phone out and you can dial in a message to your doctor, say, hey doctor, I have back pain, what's going on? And this is a super convenient way to get in touch with your doctor. And everyone has recognized this. Since the start of COVID, the number of patient messages has really taken off, and it's even eclipsed the number of patient phone calls, and phone calls is being left in the dust. But it's kind of frustrating because you write a message to your doctor, and it's texting. It should be pretty quick, but sometimes the response time is on the order of several days. And there's a lot of reasons for that, but one of the reasons is the message actually doesn't go to your doctor directly. It goes to this intermediary float pool of medical assistants and nurses that intercept and triage the message. They typically read these messages one at a time, first in, first out, and there's a lot of turnover in these roles. There's a workforce shortage for people qualified to do this work. It's really hard to train these folks to really tee up these messages and respond to them. And as a result, we've got folks that are kind of new in the role, which leaves a lot of opportunity for messages to kind of wind up in the doctor's lap, even though they're not necessarily doctor requiring messages. It's just kind of the buck stops here with the doctor. So the doctor's doing a lot of not super clinical message responding. That causes a lot of unreimbursed decision making. We call it pajama time in the biz. Doctors doing work in their pajamas after work, and that causes a lot of burnout. So to address this problem, we've created something called Provaria. It's the Providence Automated Real-Time In-Basket Assistant, a generation of kind of cute acronym names for software. Think of it like a co-pilot for a medical assistant doing patient message triage. There's two components to Provaria. There's the large language model component, and there's the electronic health record integration. The large language model looks at, it's configured to classify about 20 or so workflow-centric patient message categories. So these are things like requests for medication refills, or a question about a lab result, or an inquiry about the status of referral to a specialist, like what's going on with this referral to orthopedics. And there's a handful of acute symptoms that are pretty common in primary care. So you might be wondering, well, gosh, why use a large language model for text classification? We've been able to do this for years. And it's true. I mean, you can fine-tune a BERT model to classify these 20 categories. You need a data scientist, some annotated data, some Databricks instance, and some time. But ultimately, a lot of these workflows change so frequently, and the workflows are so different from like a neurosurgery office to a OB-GYN office. It's really unrealistic to expect the kind of data science support for our organization to kind of keep on updating their models to route these messages. So that's why in this case we're using a large language model, not for its generative capacity, but more for its the expressivity that is allowed in the prompt, that allows non-data scientists to describe the categories that make sense for their workflow, and package that up and send it off to the language model to categorize the text. And I'll go more into the language model. The second component of Provaria is the electronic health record integration. So obviously we show the category. Why else do it? But we also have some downstream workstream actions that are helpful to the medical assistants. So you've got a knowledge base that says, hey, the doctors in this clinic say for back pain, you should do X, Y, and Z. And we have things called quick actions, which are basically just buttons that you press that save you some time that otherwise it would have taken like 15 clicks. And I'll show you more about what that looks like. So a deeper dive into the large language model, everything gets kicked off when a patient sends a message to their doctor. Hey, Dr. Jones, I've been having back pain. What should I do? The prompt is then generated. So the prompt has a couple components. First of all, there's the meta prompt. This is where you kind of create the rules of the game. So you are an experienced nurse and you're good at doing triage, like you say that to the LLM. And this is where you also specify the output schema. In this case, we ask the GPT to respond with a list of JSON objects for downstream processing. Next, we do the grounding step. So this is, depending on where the message is going, that department has different categories that it cares about. So we ground the prompt dynamically based on the routing of the message. We provide a few shot examples, and then we include the message, and that's the prompt. So we send that to the Azure OpenAI GPT 3.5 endpoint. We're using Azure because it's HIPAA compliant. We're using GPT 3.5 because it's fast and it's cheap, and it works fine for text classification. The response that we get back is JSON because we asked it to be JSON. But ultimately, this is where we get into the kind of hybrid large language model deterministic programming area. Because we asked for JSON, that means we can parse it as JSON. And if someone's trying to do some trickery with prompt injection, they better figure out a way to match our JSON schema, otherwise it's not going to work. Now that we've got our prompt or our response in machine-readable format, parsed JSON, we can identify, log, and filter out hallucinated categories. So it's a large language model, it hallucinates. Sometimes it comes up with a pretty reasonable category, but it's not one of the categories that we've determined is important. So we log it, we might add it later, but ultimately don't show it to the user. Categories get shown to the user, which I'll show on the next slide. So this is I guess, representative diagram of what the user interface looks like for the medical assistant. We are running in production, but our EHR vendor doesn't like us taking screenshots of their software. So I had ChatGPT generate HTML of a inbox, and this is what that looks like. But this is basically what it looks like. You'll see on the left, we've got some patient messages. Patricia is writing in because she's got some back pain. John is asking for a medication refill. This is like Outlook or Gmail. You'll see though, there's the filter icon on above the messages. This is pretty cool because now that we've got categories, we can have the medical assistants and nurses, filter their experience to the categories they're uniquely qualified to address. And we call that working at top of license. And so if someone's asking about what time is the clinic open, you don't need a doctor for that. If someone's asking, well, I'm having like this weird symptom that I've never had before, you probably want a nurse to figure that out pretty soon. And so that filter icon, as simple as it is actually a really big deal for kind of getting the right messages seen by the right person instead of the kind of naive first in, first out approach. On the right, you see standard message, nothing surprising there. We've got the Provaria category, it says back pain, great. And then the blue buttons, these are the quick actions. These are just really common next steps that medical assistants and nurses take based on a message of this category. And so instead of, if there's any clinicians in the room, like, you have to click 15 clicks to do anything, these are shortcuts to get the really common stuff done. So send a questionnaire, it's basically like the first step for everything. Refer to physical therapy, schedule an appointment. These are really common things that happen from back pain messages. If the message is something else, the categories are something else. Finally, the knowledge base, pretty useful. This provides just-in-time training for some of the medical assistants that are a little newer to the role, instead of having, posting up PowerPoints with thumbtacks in their cube, which is what they do without in the workflow information. So last slide, we have deployed this in a pilot site in Southwest Washington State, and we're pretty excited by the results. Patients are happy. They're seeing a decreased turnaround time, almost 40% decrease in turnaround time. There's also a lot more same-day appointments for urgent issues. These are issues that maybe wouldn't have even been seen until tomorrow, but because they're able to be filtered and prioritized, they can not only be read by the nurse, but an appointment can be made and the patient can get evaluated. The medical assistants, they're happy. They're doing more top-of-license work. There's also a lot easier onboarding because they don't have to get trained for like days at a time before they can do anything. They can have this just-in-time training that's part of the workflow. And surprisingly, there's a repeated expression of like increased peace of mind. And I didn't really fully understand this, but if you imagine you're going through a bunch of kind of like, oh, this is kind of not super acute information, but we can figure this out. And then you find that 51st message, like, oh, wow, this is a really serious emergency. It's really stressful to have that on your conscience that, and if I had just been cranking through a little bit faster, this person could have gotten seen today. And so the peace of mind enabled by having these priorities is really surprising to me. I've heard it multiple times. And then because of all this kind of in the workflow training, the messages are better categorized. The messages are in many more times handled by upstream by the nurse or the medical assistant. And the cases where they can't handle them, they at least collect the right information to inform the doctor's work. That allows our doctors to make decisions with more complete information and focus on what they do best, is focus on clinical care. So that's our product called Provaria. So thank you for joining.